REVAR is better than open repair for ruptured AAAs?
Thank you, Liz. Today I'm going to talk about what's going on the other side of the Atlantic, about ruptured AAA. I recommend an open-first strategy for ruptured AAA in men based on UK in-house economic modeling. However, the European Society of Vascular Surgery recommend REVAR first strategy. So there's two organizations in Europe. One said right, one said left. Let's look about the IMPROVE study. And patient randomized out of working hours had worse outcomes. So if you come over the weekend, you will die. And then the per treatment analysis, it was just amazing. You have 24.7% for REVAR and 38% for open surgical repair. IMPROVE trial conclusion is misleading, as more than half of the patient randomized to end strategy did not actually undergo treatment by REVAR, they got open repair.
Theresa May, when did you realize that you got the wrong answer to the biggest question of our times in politics?
Well, I'm tempted to ask you, Jeremy, what you think. Do you mean that you're talking about Brexit?
Well, of course.
Right.
So the problem is that if you follow the nice guidelines, we will go in a very bad spiral direction. This pragmatic trial aimed to evaluate a work process, not a treatment modality, applicable only to the UK units. It's not a direct comparison of REVAR versus open repair and rupture aneurysm. Length mean treatment time of 180 minutes for rupture aneurysm using REVAR, as well as high misdiagnosis rate, casts a shadow of doubt over operator experience. Some patients never had a rupture aneurysm. A consultant vascular surgeon, a registrar, a consultant radiologist, a registrar for REVAR, and 2 consultant surgeons with 2 registrars for open repair. I never had that. I always have an SHO intern helping me. This is not a standard practice for rupture AAA management in any other place in the world. The IMPROVE trial exposes several flaws in the way that vascular units are run. Specialists trained in open endovascular will alleviate operation issue, which precluded patients suitable for REVAR being denied treatment and would further reduce the costs. Then let's look about what's going on in a more concentrated form. Before joining IMPROVE, 38 REVAR and open surgical repair was 90-day mortality of 13% for REVAR and 30% for open surgical repair. After joining the IMPROVE study, the REVAR is 35% death rate versus open 33%. So what happened that IMPROVE algorithm break Cambridge rupture surfaces, and they have to stop people operating because of high death rate during this. So let's go to reality situation. Accept, no fear, no limits, no excuses. Only determination and action. So there's nothing called you can do. Yes, you can do, and if you are an endovascular enthusiast like myself, you'll be able to do very complex cases with even the dress technique, which I'll show you later on. A free rupture demands REVAR, there is no other option. Opening a rupture AAA is a criminal act. The patient will die on the table. A lot of people have no idea what's going on. The one-to-one transfusion doesn't exist. You have an inexperienced anesthetist, and it will go downhill in the post-operative. Endovascular clamping under local anesthesia, a game changer of precision and safety. Do not do it blindly. Take your time, get the wire in, put the 16 French sheaths up there, and then put the balloon over the sheath so it doesn't move down, and get your registrar to hook it over there until you fire the stent from the contralateral side. Very simple to do, and if you do it every day, there'll be no problem. The dress technique, which we have popularized, which is design, reconfigure, elongate, straighten, and stiffen. We put a giant palmar stent or a 36XL stent in the proximal part, just above the renal, and from the SMA to the renal, and then they hook your graft in it. It will never move, and it will seal very well without the need of opening or doing any branches for these patients. And this is a very complex case. There's no neck at all. We put the palmar stent, and we then put the endurance stent, and you look, there's no endoleak at that patient. And it's repetitive. However, if you have a wide short neck, you could use a C-tag. If you put an AFX stent and you put a C-tag on it, you'll be able to remember this is emergency. There is no limit for what you could do to save the patient's lives. Now, this is a patient who has a bilateral common iliac. We just cross the internal iliac and we land the external iliac. Nothing happened. Give the patient Viagra after the surgery. His wife will be happy, and you have no problem with claudication or any problem with his legs. complex EVAR without FEVAR and SHEVAR. So the whole idea, I'm going to do a SHEVAR. No, I'm going to do patient-modified EVAR. You don't need to do that. You just do straightforward EVAR for the rupture. They do very well. And then later on, whenever things settle down, you could start doing complex intervention for such patients. Now, this is REVAR due. A patient came with an aortocaval fistula, 10 centimeter rupture, and it was also transfusing. So we have to put a stent into the aorta and a stent into the inferior vena cava in order to seal it. And the inferior vena cava on, we put an AFX to go down to the common iliac because there was 2 holes, one in the inferior vena cava and one in the common iliac. Again, we have to keep doing the same cases come repeat itself. This is another case, exactly mirror image, and it's just amazing the challenges that you have. I learned my first EVAR with Dr. TED International when I was having my fellowship with him in 1995, and I think this guy had the vision that all of us might lack currently and trying to be in a different direction. The 10 commandments for rupture AAA: do not kill. So we got all the amount of information and we put it through general AI. So looking for recurring pattern, machine learning, matching human cognitive capacity. We didn't even go to the super AI using quantum computer, which I'm going to show you in the talk tomorrow. And what we find that EVAR reduced mortality risk by 26%. EVAR had shorter hospital stay despite higher comorbidity. EVAR had better quality of life at 3 months, but more reoperative rates. Acute kidney injury was higher for EVAR with lower ischemic complication, definitely less blood loss in the EVAR. Now, the large study was very important because it shows that there's increased incidence after EVAR post 210, and time to LAR was shorter post EVAR than open repair. EVAR group have less dialysis need, and survival rate were similar between EVAR and open surgical repair up to 5 years, believe it or not, regardless of whatever happened to the patient. The cumulative incidence rate of rupture post-EVAR for a rupture patient is 3.4 per 1,000 person, and post-open surgical repair is 0.9. So the difference is not that great. Risk factor is age. So the younger the guy at the age of rupture, the higher risk he could have a re-rupture for his EVAR. Freedom from rupture is 99 at 3 years, and 98 at 5 years, and 96% at 10 years. Not if they survive at 10 years. Post-EVAR rupture mortality is 42% at 30 days and 53% at 1 year. Now, this is a physician-modified graphs, which is very important. Only 75% of patients achieved immediate technical success post-procedure, and 25% experienced type 1A with a fatal consequences. 55% major adverse event post-surgery, 15% 30-day preoperative mortality, and some end-delay led to fatal outcome. Progressive decline in long-term survival from 75 at 1 year to 53 at 3 years, and alarming 22 at 5 years. We have criminalized the use of physician-modified graft in our unit. Why we must follow up our REVAR? High loss to follow-up rate, 60% for EVAR, 39% for open repair. Survival consequences of follow-up of loss is increased mortality rate risk, but prior endograft significantly worsen survival after EVAR. So if you have an EVAR and you had a rupture, you still have the worst outcome from the new EVAR that you had. Gender outcome equality, unfortunately, there's no equality in here. Mortality decline over 2 decades decreased from 57 to 31 in women and 38 to 19% in men. Men had higher cardiovascular comorbidity. Women had worse in-hospital mortality as they presented older with delayed repairs. They don't make their mind easy for big surgery. Sex-based complication difference, men had worse cardiovascular pulmonary complication, women had delayed intervention. We call for a sex-specific guidelines to address sex disparities. So female have smaller arteries, all of us know that, and delayed AAA diagnosis because they come with abdominal pain. Nobody even think that's coming in from a 4.2 abdominal aortic aneurysm, while few of them rupture at that smaller rate. Lower EVAR rates in female impact survival due to anatomical constraint. African American have lower in-hospital mortality than Caucasian, despite high cardiovascular burden, and we went through all algorithm for that, and we didn't know why. Mr. Chairman, ladies and gentlemen, giant AAA must be mastered by open surgical repair in deliberate high-volume surgeon and center. AAA must be repaired on a smaller diameter, especially in women, with precision design graft to ensemble patient from oversizing with minimum number of modular or limb components. VEVAR or BEVAR must only be executed during a course of clinical trial with a study safety committee that can collapse the program when such ploys show harm, toxicity, and maltreatment to the patient.